Hi, my name is Tony Knox. I'm a neurologist at York Hospital, and I have one partner in addition to general neurology. I'm board certified in headache medicine, neuroimaging, and behavioral neurology. And today we're going to talk about migraines. It's a very difficult condition to treat, and some people have misconceptions about migraine. And so hopefully you'll have questions for me, and I don't mind being interrupted if something is not clear, so please feel free, raise your hand, speak up. That's fine. If I use too much medical shop talk, you can stop me in my tracks and ask me what that is all about. So today we're talking about taking the pain out of migraine. Migraine headaches are one of the primary headaches syndromes, and it's characterized by, not every headache is a migraine. And so migraine headaches are characterized by some very specific things. It's not always the same in everybody, but typically people have a moderate to severe headache. It lasts without treatment from 4 hours or up to 72 hours and even longer. It tends to be pulsating in nature. Typically it's on one side, but it can also be on both sides. It oftentimes is associated with light and sound sensitivity, for some people odor sensitivity as well. And there's also nausea, and in extreme cases, people can have protracted vomiting associated with their migraines. Migraine symptoms are disabling to people, and many people think, oh, what is migraine? Migraine is just a bad headache. No, migraine, it's part of, hopefully, as a result of this talk, you may be thinking about migraine in a different way. Migraine is a disease state. Migraine is a disabling brain disorder. It oftentimes has inherited from other people. So I always tell people you can blame your parents when you find out who, because people tend to do that anyways. And it tends to affect women in the prime of their lives between the ages of 25 and 55. And it can really affect people's quality of life. We know that at least 54% of the people, if they have a severe migraine and they can't stop it, they're going to have to lay down and take themselves out. This becomes very stressful, both in a family situation. You're missing the whole idea of being a family. You're missing all those favorite events. Many people miss an important event like a wedding or a christening or some other high school graduation because they've had a severe disabling migraine, and it's extremely debilitating. So we're here to talk about some of the treatments we now have, some of the treatments we've been using in the past, and also as a function of the headache center that we have at York and in Neurology Associates of York Hospital, we have available acute treatment that can hopefully ameliorate or help stop people's headaches, and so that they don't have to necessarily go to the emergency room for emergency room treatment.
Are there triggers?
Pardon?
Are there triggers? Something that was...
We're going to get to that. Yes, there's plenty of triggers. In fact,
I didn't hear you mention it when you were talking about what you were going to talk about.
I'm going to talk about lots of stuff, and it's going to be free-flowing. And so if you, I personally believe, as a person that treats migraines, that the real crux of helping people with migraine is helping them identify their triggers, and trigger management is really what it's all about. And oftentimes we have people use a diary, and it's only then when people start thinking about, what was I doing right before this migraine came on? What did I eat? What am I going through? And really mapping it out on a calendar to see, well, maybe it's every time I go over so-and-so's house, and maybe there's some allergen at their house, or, migraine control is really about trigger management. So again, it's a disabling brain condition. there's been a big marketing splash to really establish people and change people's thinking about migraine as a disabling brain condition, because most of the times people say, you know, it's just another headache, it's a little worse. And there are people that live amongst us that actually don't ever have headaches or have never really experienced headaches and never experienced migraine. But it is the second most common symptom that will bring people to see a physician, that is headaches, and for neurologists, it's one of our #1 conditions that people will come to us. So, again, we talked about the criteria. Now let's talk about strategies for migraine treatment. And I'll be using terms interchangeably. Acute treatment is, what do you take when you feel like one of your migraines is coming on? There are migraine-specific medications, and many of you might have heard of them, like Imitrex and Maxalt. These were, when they came out in the early 90s, these were like a godsend to people because never before had they had a really specific, effective migraine acute treatment. And unfortunately, they're not perfect, but we can talk about that in a little while. Some people, I'm getting back to triggers, there's preemptive treatment. Some people will avoid certain foods. I have patients that they say every time I eat chocolate, I get a headache, but I just love chocolate. So I said, I'm not sure I can help you in that regard. But, and then there's people that have, and it's been shown that people that have 4 significant headaches a month, 70% of those people feel that they're disabled from their headaches. And when you think about it, yes, there's the day when you have the headache pain. For very often people will have a premonitory symptoms working up to the migraine. They might feel off in some way. They're not 100%. They'll have the day when they have really bad head pain, and then afterwards they'll have a headache hangover. So it's not just the day then they have the really bad headache, it's that whole period where they're off. And so you can imagine the people, we talk about headache days for people, and very often 4 or 5 significant headaches can lead to 15 or more headache days per month, and oftentimes people will wind up having to call out sick. And some employers understand if they have a loved one that has migraines or if they have migraines themselves, but oftentimes employers don't really get it. And so part of this is all going to be education and the changing society's views of how they view headaches and migraine in particular. So there are some alternative treatments. This sort of gets in the idea of preempting these headaches from happening. And it's basically all the things that are popular to talk about today: mindfulness, taking care of yourself, getting regular stress-relieving therapies, massage, taking vitamins, sometimes taking some supplements can be helpful to people. Avoiding dietary triggers, and there are a lot of things people do in order to try to avoid their headaches. When those don't work, oftentimes it's like, yes?
What about Butterbur? What do you think about that? Have you heard that it's used as a...
Butterbur, I mean, a lot of people come to me and they ask about Butterbur is a natural supplement, and it has been shown to be effective as a preventative in people. There's a few, Feverfew and Butterbur. Butterbur, I think people, at least neurologists, have gotten away from using it because there's been reports that people get altered liver function associated with its use. So that's like the kiss of death for a practitioner. Many people come and I ask them about supplements, and only to, I mean, I don't really mind them taking supplements as part of their treatment if they think it's going to help them. But again, not to be a naysayer, this vitamins and supplements and herbs are an unregulated industry. Very oftentimes we don't know what's in them, and they may not have what they purport to have in them, and maybe not in the concentration. So it's really kind of, if you trust the source, if it's helpful, I don't have any issue with that. Many people, they don't like taking a pill. I don't want to take medicine. And so they have a certain view of the world, and that's fine. And we try to accommodate those people. So if taking a pill doesn't help folks, then, let's see, I'm having problems here. Oftentimes, when you can't stop a headache, you call your primary care doctor or you call your neurologist, and what do they say? Go to the emergency room. And very oftentimes, people, when they go to the emergency room, unfortunately, in some emergency rooms, hopefully not York, you're treated like a second-class citizen if you have a headache. Oh, there are more important things to take care of. Or you're drug-seeking. And all of these things come, and so many times people say, oh, that's the last place I want to go to. So that's why we have a program. If some of the things that we do help, then you can call and hopefully the same day get an appointment and get treated the same day for while you're having your headache to try to stop your headache. This is a list. It's of the triptans that people can take, which are migraine-specific medications. Other times people will use other medications like anti-inflammatories. Tylenol works for many people. Ibuprofen, Aleve, all of these can be excellent acute treatment, so-called rescue medicine or abortive medicines. If you take it early enough, sometimes you can head off a migraine with taking these medicines. The other kind of medicines that we recommend is doing preventative treatments. Like oral medicines, oftentimes they're blood pressure or seizure medicines. That's their original indication to use them. But oftentimes we know that people taking small doses and sometimes larger doses of these for a period of time can reduce the frequency and severity of their headaches. When people come in and they ask about headaches, I never make the mistake of promising them that I can get rid of their headaches. But I know with certain treatments I can reduce the frequency and severity of those headaches. So if we do manage to suppress their headaches, I'm just as happy as they are that we are able to do that. Other things for people that we do in our practice include Botox. It's not cosmetic, it's used, and it can be effective in treating people with chronic migraine. Now, chronic migraine is a term, some people think it's an invented term for the pharmaceutical companies, but we make a distinction between chronic migraine, that is people having 15 or more headache days, versus episodic migraine having 14 or less headache days per month. And then we live in exciting times. There are new medicines coming out that are really taking the latest science, and there are new medications, these new CGRP medications. CGRP is calcitonin gene-related protein. That's why we call it CGRP. It's a little bit less of a tongue tire. And they've been proven very effective. They're injections. People do them once a month. There's one variety that you can do quarterly, and they're very effective and have been very effective in some people at reducing their headaches. Other oral medications, these are some of the ones that people typically take as a preventative. Getting back to supplements, very oftentimes I recommend, and there's good science behind using riboflavin or vitamin B2. I always warn the people that if they do go with that treatment, don't be alarmed if your urine is the most fluorescent yellow you've ever seen, but that can happen. Propranolol is a blood pressure medicine, but many blood pressure medicines are helpful. Amitriptyline is an old drug. It was used as a antidepressant, is one of the tricyclic antidepressants at higher doses, but at low doses can be quite helpful. Oftentimes we try to use drugs that have a double effect. Amitriptyline is oftentimes, it's been used for a number of different conditions. If you have trouble falling asleep, sometimes a small dose of amitriptyline can help as a migraine preventative, also help you sleep. Sometimes it's given with people with irritable bowel. It can help with irritable bowel symptoms, but also act as a migraine preventative. Calcium channel blockers as well. These are blood pressure medicines that have been used. And probably the most effective oral medicine that's been used as a migraine preventative is topiramate or Topamax. Unfortunately, only a certain people can use this medication because there are a lot of side effects associated with it. It is a seizure medicine, and there are some very specific side effects associated with it, like one, it makes people dopey and has earned the nickname Dopamax because it can affect people's thinking, and when they have word finding difficulties when they use it, and that can lead to some embarrassing moments. It also can cause tingling in the face and hands that can be very distracting to people, so it's not for everybody. Botox become very popular. It's part of our culture. We have we always hear about Botox. Oftentimes people come, oh, yeah, can you do the Botox here? They're talking really about fillers and cosmetic uses. We use Botox, and this has been a proven injection pattern. It's not really these tic-tac-toe boards. We don't make a tic-tac-toe board on people's heads to do these injections. But they are 31 different sites. They each receive 5 units of Botox every 12 weeks. And this treatment has been a very effective treatment at reducing people's headache frequency and severity. People can have a dramatic response to Botox. Now let's talk a little bit about CGRP. CGRP was identified, the predominant, I don't want to get too much involved in the science, but we're thinking now the great sensory nerve of the face and the coverings of the brain is a nerve called the trigeminal nerve. It's the 5th cranial nerve. It is responsible for head pain and face pain. Very often, the activation of this so-called trigeminal system will cause blood vessels to dilate and give you that pulsating feeling in your head when you have a migraine. That symptom is mediated by CGRP. We know that people with migraines, if you were to volunteer for this and have blood taking off your jugular vein while you're having a migraine, those people have elevated CGRP levels. We know also that if we inject migraineurs with CGRP, every single one of them will get a headache. They may not get it right away, but within a few hours, all of them will have had a headache. So once this was found out, it seemed like an excellent target to try to interrupt so that we could interrupt headaches. And that's what we've done. There are 3 drugs on the market. They're all very highly selective, what we call monoclonal antibodies. That means they bind, they're like one of our own antibodies, they're humanized, and they bind specifically either to CGRP, the chemical that's released from the trigeminal nerve, or they block the receptor for CGRP. And in this way, they can be very effective at preventing both episodic and chronic migraine. There are other things that we do acutely and also on a regular basis for some folks, and these are nerve blocks and trigger point injections. Very oftentimes people will come in, they'll have tremendous pain. Many people have a neck component to their headache. They have pain in the back of their head, the front of their head, all over. There is this connection between higher cervical level sensory fibers and the fibers of the trigeminal nerve. There's a lot of crosstalk between them. So you wouldn't think it, but if you were to block a nerve in the back of the head, the greater occipital nerve, people oftentimes with a frontal headache, it will go away, like within minutes of getting the injection.
What are you injecting?
An anesthetic, like lidocaine or bupivacaine, marcaine, sensorcaine. Likewise, there are, well, we never inject down here, but mostly in the neck and shoulders, you can inject little doses of anesthetic and relax those muscles and prevent some of the pulling on the nerves that innervate the back of the head. And lastly, we do acutely and as a preventative for some people, these so-called sphenopalatine ganglion blocks. That's why we refer to them as SPG blocks. And if you were to split somebody down the middle, let's see if I can. Well, in any case, in the back of our sinuses, there's a cluster of neurons. And if you spray anesthetic on those neurons, you can reduce a lot of facial pain and sometimes people's headaches. This is especially effective not only for migraines and acute migraine pain, but also for people with another, some people would say the worst headache you could get, cluster headaches. And this can be a very effective treatment for that. Thank you all for listening. Yes?
I don't know if you could answer this, but I'm sure someone in your hospital, all these medications, there must be a certain component of them that are not covered or covered by a lot of our Medicare pharmacy plans. So would we find that out?
So the CGRP medicines, the new medicines, yeah. These companies, unusual, it's easy to bash big pharmaceutical companies. They've priced this and tried to price it very reasonable for people, but I mean, people on a fixed income, it's a problem. So not only do they have reduced pricing for people, they've partnered with organizations like Cover My Meds and some other organizations that provide grants that will pay the difference. I mean, some people say, oh, you can get it for $200. Well, $200 is a lot of money for people on a fixed income. And so you've really effectively stopped those. And we try, it takes a lot of work from my staff to really try to put the medicine in people's hands. York Hospital has also made a commitment to people, if you cannot get medicine or afford medicine, we have a patient assistance program, prescription assistance. It may take a while to get it, but have been very successful at getting people to at least try these. I think, you know, many people, that's one of the things about migraineurs, they're always willing to try something to stop their headaches. They're really motivated and can be motivated to stop the pain, keep them back, keep them in the game, do whatever they have to do. So trying these would be helpful. And not everyone works for the same people. We've had failures from each of them, and then successes when a successive medicine has been tried. So that can be effective, yes.
Would there be any difference in any of the treatments if it was migraine related to post-concussive syndrome?
Post-concussive syndrome, the people oftentimes, you know, there was headache and facial pain symposium this past weekend at Tufts, where I had the privilege of presenting. And one of the things one of the speakers talked about is we do have this phenomenon where people after a concussion will now they might have said, I never was really bothered by migraines, but after the concussion, now I have this migraine thing that I didn't want, and it persists even after doctors say, oh, you should have recovered from the concussion now. It is felt that people where that happens were migraineurs, that the injury just unmasks that property. And so they should be treated like any other migraineur. Myself, oftentimes after the acute concussion, I found that nothing really works to quell the pain. One of the things that has been explored is using the catheter to use the SPG blocks weekly, and that shortens the period of time when they have that really acute pain. Yes?
A few questions. Do you differentiate between chronic daily headaches and chronic migraine? I've heard the term chronic daily headaches.
Yeah, the language is can be sometimes difficult. There are a lot of experts that don't believe it's chronic migraine, chronic daily headache. The more important thing is many people, because they've been ineffectively treated, go from being a chronic migraineur to a chronic daily headache. And there are different components to their headaches that may be triggering people that can be addressed.
And when you talk about the CGRP, you said there were two ways it would work, to either bind or block. How do you, as a physician, differentiate which one to use on a patient?
It's a toss of the coin for me. Okay. There's one of them that has been reported to accentuate constipation. So if somebody has severe constipation or is struggling with severe constipation, I tend to shy away from that drug. That's one of them. Two of them have a self-injector, and they're pretty easy to use. But one of them is a small needle, and if people are needle phobic, actually you can come into our office and we'll inject it for you. But if people are really needle phobic, then I tend to shy away from those. They're all effective. They've all been studied both in episodic and chronic migraine, and all of them are effective.
And the last question is, can a person have like chronic headaches intermingled with or intermittently with clusters? And how do you define a cluster?
Yes, the short answer is yes. Cluster is like no other headache that I've treated. You can tell a cluster patient now from a migraineur, because migraine people want to seek out a dark room and lie down. Cluster patients, and cluster headaches are characterized by severe, usually eye pain or around the eye pain that's so severe they've been unfortunately called suicide headaches, because they're very difficult to treat and the pain is just blinding, in a sense that I know those patients because they're up, if they can, they're up walking around. They cannot stand it. And that's a different, we found that sphenopalatine ganglion blocks can be very helpful. There's a lot of things that have been tried. High flow oxygen for cluster headaches. There are some of the triptans work for people with clusters, but the mainstay for basic treatment is calcium channel blockers. And again, they're called clusters because they tend to be seasonal, and a group of them oftentimes occur at the same time every day, and the days that they have them are clustered, and so oftentimes people will have them both in the spring, and then they'll have a period of reprieve, and then in the fall they'll come back. And then there are some unfortunate people that will have chronic cluster, which is very difficult to treat. Welcome.
Is the Avjoy easier to get than the Aimovig?
Pardon me?
Is the Avjoy easier to get than the Aimovig?
I think they're all better now. Aimovig was the first one to come out, and they had something called the hub, and the hub was no good. And people languished in the hub and weren't able to get it. Now they've, I think the other two companies benefited from their failure, and so they've joined the group. They've actually come out with new copay cards for people.
Minimum big, if you have Medicare, Medicare is a $750 copay.
Yeah.
They will not deal with it.
Well, that's not.
Even with the copay, the card.
But people on main care, we've been successful at getting them their medicine. You call Donna, yes.
Donna's the one.
Donna is the one, yes.
Yeah, there's people who have a real problem with this. Do they need oftentimes to leave the workplace?
Oh, absolutely. Absolutely. I've had migraines since I was a child. I'm the only one in my family with migraines. And so there wasn't a lot of understanding there. My father's from the county, and when I would tell him, oh, I can't do whatever physical work, which is a feature of migraine, he said, why not? I said, because I have a headache. And he denies it now, but I brought this up to him. But he said, headache is just another word for lazy. And so it was tough love, I admit, but very oftentimes people are blind. They cannot. I think one of the most disabling features of migraine is the nausea, and to be nauseated all the time. You know how you feel when you're nauseated. Well, think about having that and going on for days, and not wanting to take. That's why some injectable medicines were very more attractive to people, because people don't want to drink water. People don't want to do anything because it might provoke the vomiting. So in a workplace situation, it's just terrible. Yes?
What does it mean when you have white spots on your brain that are caused by the migraine?
That's open for debate. Sometimes the spots change. They don't. Sometimes they feel that the blood vessel in the area where that spot was has created some inflammation, and the supporting cells of the nervous system proliferate, and then that's what produces that white spot. I think some people, neurologists included, have erroneously concluded that, oh, those are little strokes in your brain, and that's not true. Although, from an epidemiological point of view, people with migraines are more apt to get strokes later in life. So, yep.
Do you have some common triggers that you could talk about? There's like the top 5.
My triggers?
What triggers that would cause
the top 5? Okay.
Yeah.
If the top 5 is not getting enough sleep. A big one is too much sleep. People always say, oh, I want to sleep in on the weekend. Bad news, because they can do it. Common food triggers include anything that contains nitrosamine compounds, like a lot of what our cured meats are with, lunch meats. Citrus can be a provocateur to people. Bananas, red wine, pickled fish, the sulfates in both red and white wines. The food triggers go on and on, but stress is a major one as well. So those are, and then there are particular headaches. Some people work all week and are stressed, and then they say, oh, I can't wait to get to the weekend and I'll be able to do this. And then the weekend comes and then they get this terribly disabling headache, and those are called letdown headaches. The minute you let down your guard, then these headaches emerge. So there's a lot of different triggers, but the sleep and stress are the two biggies that I see. Yeah.
It does have sleep.
Pardon?
A person that does have sleep problems and takes Ambien, can that bring on a migraine?
I don't see Ambien as something that brings on a migraine.
Pardon me?
I don't think Ambien is something that brings on a migraine. Although people misuse Ambien, they shouldn't be taking it every day. It should only be used as needed, and I think people become psychologically dependent upon Ambien, and they get into a panic. I can't fall asleep, but we like people to get away from using it every day.
So I have two questions. The first is I have a 14-year-old daughter who suffers from migraines. They're infrequent, but I'm wondering if any of the things that you talked about would be applicable to someone in her age group. And the second question is, the major problem for her is anxiety about getting a migraine, especially at her age. You know, she wants to be involved in lots of activities, but then she gets really stressed out about the possibility of a migraine happening when she's out doing something and not at home with her parents, you know.
The anxiety about getting a migraine is real. I think that's even part of the disability. People don't put themselves into situations where they think will trigger their migraines. And again, with children, oftentimes parents are reluctant to give them medicine. So the first line of things that I recommend is the riboflavin. Daily riboflavin, 400 milligrams. Again, it's a lot of riboflavin. And patience, because it takes about 8 to 12 weeks to really kind of kick in, if it's going to kick in. And that would be my first line of treatment. Then I think a small dose of amitriptyline, if people can try it, that's usually for the pediatric population, the ones that we try first.
Could you move the mic so that we would pick you up? We can't hear you.
Sure. Yes.
Yeah, a friend of mine from England claimed that drinking tea was an issue with her migraines.
Well,
The problem for her.
my mom's British. I think I've had more tea than most. She used to say that it wakes her up in the morning and puts her to sleep at night. It warms her when she's cold. It cools her off when she's hot, and so on and so forth. It contains tannins. Tannins oftentimes can be provocative to some people, but oftentimes things with caffeine can, for people that are naive to caffeine and don't drink caffeinated beverages, it actually can be helpful. The thing that we caution people about is overusing caffeine, and if you're caffeinated all the time, you know, you're just one cup of tea or one cup of coffee or one diet soda away from triggering a caffeine withdrawal headache. But tea is a big provocateur because of the tannins in them.
Other friends of ours used to say she was only using that as an excuse for getting in everybody else's business. And that's what was giving her the migraine instead of the tea. So.
I have no comment. Yes. Yes.
Could you say a little bit more about what happens to the blood vessels in migraines? Are they, is it a dilatation problem that causes the migraines?
The short answer is yes. I believe that especially the blood vessels in the coverings, the so-called meninges of the brain, they're heavily invested with trigeminal nerve fibers. Remember trigeminal being the great sensory nerve of the head and face. When the vessels dilate, they activate these fibers, and you can envision almost a feed-forward mechanism. The dilation causes more release, which causes more headache. And people experience this where the headache just seems to go on and on and on and on, and they can't interrupt it. So we try our best to somehow break that. Oftentimes sleep is restorative to migraineurs. If you can, and that was the object of a lot of emergency rooms, if you can get that patient to sleep, then oftentimes they can wake up, not always, but oftentimes they can wake up without a headache. Yes.
I've heard that magnesium supplements can help with migraine frequency, but I noticed you didn't mention
They won't
that,
hurt
so-
you.
Okay, but you don't think that it does?
Well, I don't. The things that don't hurt people, I don't necessarily discourage people from doing. I mean, eating lots of fruits and vegetables, you'll get a lot of magnesium that way. But I've recommended slow mag, taken with food in conjunction with the riboflavin. Oftentimes that's the formula. If people have been on medicines and then decide they want to get pregnant, they transition off things with that could questionably harm the fetus and onto riboflavin and magnesium. Yes.
Is there any connection between migraine and vertigo?
There used to be a term. There's a classification of migraines that is, if you ever get a chance to see it, I don't recommend it. It's ridiculous. It's like everything from a migraine when you stub your toe, I'm being facetious, to every conceivable migraine. But what you're talking about is what was formerly referred to as basilar migraines or vestibular migraines, and people oftentimes can get symptoms of vertigo associated with that. Now we refer to it as migraine with brainstem features or migraine with vestibular features. We don't really, it's still a migraine and we treat it like a migraine.
So there is a connection?
Yes, oftentimes they would say, oh, this is because the artery that feeds the back of the brain, the brainstem, is the basilar artery, and so that's why they refer to them as basilar migraines. And there was this idea, triptans, the Imitrex and Maxalt that they use for headaches, were supposedly not safe because it would cause greater constriction of the basilar artery. That's been refuted many times.